On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Implementing a Bundle-Based Improvement Initiative to Prevent Catheter-Associated Urinary Tract Infection in the ICU Setting. My name is Christine Bingman, and I will be your moderator for this program. Now I'd like to introduce our speaker for the webinar. Holly Shadle is currently a nurse practitioner in the dermatology department at UPMC, North Central PA, and adjunct faculty for the nursing department at the Pennsylvania College of Technology. Prior to that, she worked with UPMC Williamsport's Neuroscience Center as the lead advanced practice provider for the neurosurgery department. Holly is a two-time honors graduate of Duke University in Durham, North Carolina, where she obtained a Master of Science in Nursing in 2017, followed by her Doctor of Nursing practice in 2019. Before her career as a nurse practitioner, Holly served as a registered nurse since 2009, working in both critical care and home health settings. Holly, I will now turn the program over to you.
Thanks, Christine, and thank you for that wonderful introduction. Also, hello to all of the participants. I wanted to start by thanking everyone for joining us for today's presentation. I hope each of you are able to take something away that may be useful in your day-to-day practice. So first, we're going to start looking at the objectives for today's presentation. Ideally, at the end of this presentation, you will each be able to explain the negative implications of catheter-associated urinary tract infections and why reduction is so important. Identify the most effective evidence-based intervention strategies for CAUTI reduction. Describe the two practice-based interventions used for the initiative. Identify and explain the three educational components necessary for achieving successful CAUTI reduction. And describe how the initiative could be implemented and sustained in a larger acute care setting and how this could be adapted in the reduction of other healthcare-associated infections. I wanted to start off today's presentation talking about the background and significance of catheter-associated urinary tract infections. I think one of the most significant reasons to focus on CAUTI reduction is because these hospital-acquired infections are preventable events, and they can lead to poor patient outcomes and higher healthcare costs. Indwelling urinary catheters are actually quite common in the acute inpatient setting, and current data actually reveals that 15 to 25% of all inpatient populations will undergo catheterization at some point during their hospitalization, and around 75% of hospital-acquired urinary tract infections are attributed to these indwelling catheters. Catheter-associated urinary tract infections were the second most commonly observed healthcare-associated infection from 2015 to 2017, and CAUTIs actually account for approximately 15% of the reported healthcare-associated infections annually. So you can see, based on these numbers, you can appreciate why reduction and prevention are so incredibly important. So my local institution was no exception to the data that we just talked about in the previous slide. Prior to starting this improvement project back in 2018, the data from my local hospital revealed a total of 13 reportable CAUTI events in 2018, and 6 of those actually occurred within the ICU. However, when we were looking at patient volumes and the projected standardized infection ratio expected for our hospital, we should have been reporting no more than 4 CAUTIs per year. These findings ultimately were what prompted the quality improvement initiative that we're about to talk about, with the primary goal of reducing those CAUTI rates in the ICU. I just wanted to take a second to dive a little bit deeper into the effects of CAUTIs and the effects they have on patient outcomes and healthcare costs. Looking specifically at patient outcomes, as you can see here in this slide, AHRQ's national scorecard for hospital-acquired conditions reported approximately 161,000 CAUTIs in 2017, with a projected excess mortality rate 0.036 per event. Annual data also demonstrates that CAUTI incident rates are consistently higher in the ICU settings, which we have seen at our institution as well. And per CDC data, 45% of the observed CAUTIs were reported by ICUs. Additional data also indicates that pooled mean CAUTI rates per 1,000 catheter days in non-ICU patients typically is anywhere between around 0.1 to 3.1, but in the ICU and critical care settings, that number actually goes as high as 1.2 to up to 5.3. So looking at those numbers, it's important to realize that those also really drive up healthcare costs, which is another crucial point of this. The total cost for CAUTIs can fluctuate pretty significantly depending on what institution you're at and what study you're looking at. But according to AHRQ, average CAUTI-related costs were estimated to be approximately $14,000 per hospital-acquired condition event, but they could range anywhere from $4,900 to as high as $29,743. Another study looking at the cost and the effects that these had found that the per patient cost can range anywhere from $500 for your basic uncomplicated UTI, but can go up to as high as $3,000 when patients also get secondary complications like bacteremia. I think it's also important to realize that there are some other indirect costs related to CAUTIs that a lot of people don't really think about or realize. I'm sure many of you are probably familiar with the Center for Medicare and Medicaid Services. They have the Hospital-Acquired Condition Reduction Program. So this program basically collects data on patient safety events and certain healthcare-associated infections, which also includes CAUTIs, and then ranks hospitals based on this information and releases these results to the public. This information can also be used for CMS to give penalties and reductions in reimbursement as well. So those are kind of some indirect costs that people don't necessarily think about, which also help to reinforce why driving down CAUTIs can be so important. Now that we really understand the problem and the related consequences, the next question really is, what can we do to fix them? Fortunately, CAUTI reduction has been the focus of several studies over recent years, partly because of these increased rates that we have seen. Many of these studies started out focusing on single intervention strategies to achieve reduction. Some of the most effective interventions included things like using daily checklists, implementing removal protocols, and also having things like clinical support tools like pop-ups and reminders built directly into the EHR. Using interventions like daily checklists and nurse-driven protocols for catheter removal have been found to reduce CAUTI rates by 1.42 per 1,000 catheter days, which is very significant. Other effective single intervention strategies have focused solely on education, which have also been very promising. There are some other single intervention strategies that I was actually kind of surprised to read about, but things like focusing on use of antimicrobial drainage bags were actually found to be relatively ineffective, which I also think is important to know because a lot of times those products can really increase costs for the supply. Evidence from several literature reviews found that using a bundled approach that encompassed several of these interventions similar to what we talked about in the previous slide, several of these evidence-based interventions used at the same time can be very, very effective for CAUTI reduction. For example, one study actually combined 5 separate interventions into one improvement project. They included use of a bedside reminder tool for the nurses. There was an educational campaign that they used. They improved their orders within the electronic health record, and they also incorporated some clinical support tools. They added a catheter removal order and a protocol outlining specific care after catheter removal. This project occurred over a total of 3 years, and results revealed a significant reduction in the overall CAUTI rate, as well as a 35% reduction in catheter use. Another recent experimental study chose to use a bundled approach as well. This one was a little bit different and involved a lot less interventions. It just focused primarily on using a daily urinary catheter checklist. And then they also incorporated a biannual training program for their CAUTI prevention. Ultimately, with this program, the CAUTI incident rate decreased from 14.9 to 1.1 per 1,000 catheter days, and urinary catheter usage decreased from 73.1 to 45.6. So I find that study to be very impressive, and I really like the approach that they took. AHRQ has also suggested that using a bundled intervention model is the best approach for CAUTI reduction. So based on the studies that I kind of reviewed during the literature review and also those recommendations from AHRQ, that's ultimately why we decided at our hospital to use a bundled approach as well for the improvement project. So this will lead us directly into the improvement project and how we kind of went about creating it and implementing this. Looking at the project aims here, we went into this project with 3 specific goals in mind. The first and primary goal, as we discussed earlier, was to really reduce the total reported catheter-associated urinary tract infections in the ICU. The second thing we wanted to really do, because we noticed this was something that was a little bit higher for us as well, was to reduce the total number of urinary catheter days in the ICU. And the other thing that we noticed that we thought was contributing to some of our higher rates dealt with more of compliance and documentation. So we decided to make the ultimate goal to improve compliance and indwelling catheter-related documentation within our EHR. So now we're going to kind of look at the important elements for CAUTI reduction, specifically focusing at this point more on the education and what's important to make sure that your staff are aware of. The AHRQ's implementation guide toolkit for reducing catheter-associated urinary tract infections in hospital units actually outlines 3 main educational components that are really crucial to having a successful CAUTI reduction program. The first is to focus on suitable catheter use. You really have to make sure your nurses understand why they are using the catheter and that the reasons that they are using them are appropriate and that they haven't changed. And these are one of the really important things that you want to focus on, because inappropriate use can unnecessarily drive up these CAUTI rates. The second is to focus on proper insertion and removal. This kind of seems like common sense, but a lot of times it's simple things like using proper aseptic technique that can sometimes lead to issues with the catheter-associated infections. The final focus was to maintain appropriate maintenance of the indwelling urinary catheter, because ultimately the maintenance really can help to prevent infections as well. In addition to these 3 components that we just talked about from AHRQ's toolkit, the interventions for the bundled approach were also modeled very closely after the guidelines laid out in UPMC's Reduced Catheter-Associated Urinary Tract Infections CAUTI Best Practice Guide. The reference for UPMC actually included several great tools, one including general catheter education, also included directions and resources for hands-on learning, and recommended skills, and also some videos that were available, and evaluation checklists that you could model yours after for skills evaluation. So the interventions used for the entire project were kind of broke up into separate categories. The first set of interventions focused specifically on education, very similar to what we just talked about in the previous slide. How we went about doing that is we actually had a didactic component that we used, but then we had a second hands-on skills and competency session. The didactic component of the educational intervention consisted of required education narrated modules via PowerPoint that they had to complete. These also included some instructional videos. The didactic portion was really quite comprehensive and included CAUTI definitions and related information, including things like CAUTI-specific criteria. And that was important as well, because we have to make sure that what we're calling CAUTIs truly are these meet the appropriate guidelines. It was also important to look at things like symptomatic versus asymptomatic UTIs, and things like appropriate urine specimen testing and collection techniques, as well as care-based education. We had found a lot of times that nurses were doing things like they were pulling the samples directly from an old bag versus taking them directly from the hub. It was small things like that that we also thought to improve the infection rates in the end. These didactics also included information pertaining directly to the patient care. We talked about topics like the indications and contraindications for indwelling catheter use. We also talked about alternatives that were important to not forget about as well, including things like external catheters, things like the Texas condoms, and also timed voiding. We also talked about proper insertion and removal and appropriate maintenance and care, and other basic but essential topics were reviewed, including reinforcing sterile techniques for insertion, and also catheter drainage bag positioning, making sure your bag was appropriately positioned on the side of the bed, making sure you had the loops correct in your tubing, and also techniques for proper daily catheter care. So when we got into the discussion of appropriate catheter care within the didactic information, we talked about the appropriate catheter care with using soap and a washcloth and water versus the improper cleaning, which a lot of times we were finding using things like the perineal cleanser spray for catheter care, which are actually contraindicated and have been found to increase CAUTIs. So those are really important things to kind of point out in our education as well. Once the nurses finished doing all of the didactic elements of the education, the next part was they were required to attend a hands-on skills competency session in the ICU, and each of the nurses were required to complete skills evaluations. on each of the components of indwelling catheter care. These included a lot of different things. We started with insertion, and we basically had them go through the entire skills checklist and made sure they did that appropriately. This was followed by evaluating them on removal. And then we went to daily care, and we also evaluated them doing specimen collections as well. These were held at various intervals throughout a 1-month period. And we also tried to accommodate the staff and all shifts to promote maximum compliance. So sometimes we would have them, early in the morning. Sometimes we would have them in the middle of the day. Other times we would do them in the evening, just to make sure that all of the shifts would have a convenient time for them to be able to stop and do those. We also really made it a point to design them in a way that were very short and efficient, so that the nurses really didn't have to spend a lot of time there. They could come in, they could do their skills sign-offs, and they could get back to doing what they needed to do. We also set up individual testing on a case-by-case basis, and basically how we did this is we had select supervisors or super users that were kind of trained in how to do these skills checkoffs. And for those who were unable to attend the sessions for, approved reasons, then we could accommodate them separately to make sure that everybody was able to get the education. We also really trying to minimize any extra costs that were incurred with the project. So with doing that, we actually encourage the nurses to find times during their scheduled shifts to complete the education. And then to kind of track all these, what we basically used is we had a special tool that we used. It was an online tracking tool that allowed us to ensure that everybody was completing the learning modules. They would kind of have to complete a self-test at the end and then submit that, and then it would kind of go through into this tracking device that we had, so we were able to track everybody that did it. And then during the skill sessions, we actually had just basic sign-in sheets that people use that we would use to monitor and make sure that we had got everybody, all the nurses in the ICU. So moving away from the educational component, the second kind of portion of this improvement initiative really focused on practice-based interventions. The first one involved implementing an electronic daily checklist for indwelling urinary catheters. This was a little bit more challenging. We actually had to create a checklist through Excel, and our nurses were able to access it via SharePoint. So the nice thing was it was easily accessible to everybody. And this actually included documentation on urinary catheter insertion dates, whether the urinary catheter order was present, the reason for continued use, and whether patient education was documented, and daily catheter care was documented. A lot of times this is something that at a lot of places I think they have used as clinical support tools, and they've been able to incorporate them through their EHR and things like that. We were talking about with pop-ups and everything. For us, at this point, it was a little difficult because we were actually in a transition period where we were moving from using an old EHR system to a new one. And it was going to be a lot of work and expense to kind of build this checklist directly into our EHR. And that's ultimately why we decided to use the Excel and SharePoint approach. But I think it's important to know if anybody tries to implement something similar at their institution that a lot of times these checklists can be built into the EHRs as well. So with the checklist that we use, staff members were required to complete the checklist once daily. We set it between very specific hours to kind of create that routine for the nurses. And they had to do them between 7 p.m. and 11:59 p.m. every night. There was also automatic email reminders that would go out to all staff to remind them to complete these. And the supervisors on shift were also able to kind of keep tabs of the rooms that hadn't been documented yet, so they could easily remind the nurses that may have forgot that they had to do their checklist for the night. The electronic format that we used was really multi-purpose. Kind of a long time ago, back in the day, they had something similar where it was like a paper checklist that the nurses would have to do for several different things. One of them included catheter care, and then they would have to kind of check these off. But then they would kind of get piled into a room on a desk, and they would get lost. People would forget to do them. They had to be hand tallied, so it was very difficult. And by using this electronic format, it really helped us to increase the compliance of completing the checklist daily, simply because of ease of use. It was very easy for the staff. They just clicked on the link, they opened it, they answered their stuff, and then they were done and can move on to the next thing. It really also made it easier for the supervisors as well because it decreased their workload. They were able to easily track it, see who hadn't done it, and also it improved the accuracy of the data that we collected because there was a lot less room for errors because it was all automated through the checklist. The other practice intervention that we focused on involved implementing UPMC's version of the nurse-driven protocol for discontinuation of indwelling urinary catheters. In the past, we had a really old urinary catheter remover protocol, but it was one of those things that it was kind of antiquated and it hadn't been used in years. And it was one of those things that if you looked in the policy, you really couldn't even find it. Some people thought we had it, some people thought we didn't. And there wasn't really a lot of continuity across the board with that. And ultimately, we had decided to go ahead and try to update that and kind of re-implement it in the ICU as part of this project using UPMC's version of that protocol. If you look in the slide here, you can actually see on table 2 here over in the figure on the right, you can actually see kind of the version of the removal protocol that we use. And those are kind of a pretty standard thing. You know, you look at was the order present, yes or no, and then you kind of move down from there, kind of like a flow chart, and it kind of gives you those criteria, you know, based on whether or not you should leave it in or call a physician or whether you truly can remove it as a nurse without that order. And as a provider, I can tell you that this is very helpful as well. A lot of times it's easy to forget about the urinary catheter as a provider, and then they end up being in for longer than they need to be. And this really allows the nurses to really take charge and kind of takes away the issues with that. So I think that a removal protocol is very important. And I also wanted to point out with this is also something that can easily be built into EHRs. And in most of these newer systems really is in there. For us, we were not at the point where we could build that in, so that could make it a little bit more challenging, but fortunately now we do have it set up within there. So next we're going to get into the analysis strategy and really get into the measures and methods that we use for our data collection. As you remember from the earlier slide, the first goal was to reduce the number of CAUTIs reported in the ICU during the intervention period. Analysis for this aim involved a percent change calculation. And you can see we use IBM SPSS version 25 for everything. And we set our statistical analysis for an alpha of 0.05. So then we kind of move into aim 2 and how we kind of evaluated that. The second aim focused on a targeted 20% reduction in total urinary catheter days by the end of the intervention period as compared to the pre-intervention phase. To analyze this objective, we use an independent t-test. So how we did that is we actually took weekly counts of total catheter days that we had collected over that entire 8-month period. This gave us a total of 16 data points for each 4-month interval. And then using this data, the independent t-test was used to compare the overall mean catheter days for each time frame. And then we used that to evaluate the results for the overall statistical significance. Additional measurements for this aim also included a percent change calculation between the intervals to analyze the overall efficacy of the project intervention. So moving in here to the final aim, the goal for this one was to improve the compliance for urinary catheter-related documentation. And we kind of touched on that earlier. That was really important because a lot of times if the documentation isn't appropriate, then a lot of times you can't even track your trends or see where your issues were when you're trying to figure out where these extra CAUTIs are coming from. So we really wanted to focus on that to kind of help give us kind of long-term improvement and know where our kind of shortcomings were. To evaluate this aim, we actually used 30 patient records and we audited them from each 4-month interval. Samples are randomly selected using a very systematic method that we had created. And we did this just so we could kind of increase generalizability with the population. Each of these records were individually audited, and we looked at several different factors. We looked at the inclusion of the insertion date, the presence of an order. We looked at the reason for use, and these were all laid out within that checklist as well. And there's very specific things we follow the appropriate reason for use, patient education, and also catheter care. So we had compliance for the overall completion. This was defined as actually completing all 5 elements appropriately. But then we also decided to individually evaluate each of the separate components and analyze those separately. Breaking down the analysis of each element, this allowed us to really determine those trends and reasons for use, but it also allowed us to identify those areas that required specific improvement or things that we might have to go back and revise. And then compliance rates were generated for both overall and individual element completion for each of the 2 intervals, and then we compared these using Fisher exact tests. So now we're going to kind of get into the results of the project here. So looking at aim 1, as you can see in the slide, we fortunately were very successful at achieving our first goal. Implementation of this bundled intervention model really did correlate with the reduction in the ICU CAUTI rate. You can see here during the pre-intervention period, there were the 4 CAUTI events reported hospital-wide, but then there were 2 of those that happened in the ICU. So 50% of our, CAUTIs were occurring in the ICU in that pre-intervention period. However, during the intervention, we were very happy to report that the ICU actually didn't have a single CAUTI during that entire 4-month period. So based on those calculations, this revealed a percent change of 100%. Further calculations also revealed the CAUTI incident rate decreased by 1.33 per 1,000 catheter days, which we also felt was a huge success. And these results really were in line with one of those studies that we talked about in the previous slide, where a similar bundled approach found 1.42 reduction as well. So we were obviously really thrilled with these results, especially because reducing the CAUTI rate really was our primary goal for this initiative. National estimates suggest that each reported CAUTI is associated with an average of $14,000 in additional costs for a healthcare facility. And we had talked about that earlier as well, the significant costs that are involved with each urinary tract infection related to catheters. So if you look at that, based on these calculations alone, this improvement project may have avoided our hospital nearly $28,000 in additional costs, which is also, a really important finding. If you remember in the data from one of our earlier slides, the ICU also accounted for nearly 50% of the hospital's reported CAUTIs back in 2018. However, with the significant reduction seen from this project, this put the hospital closer to achieving its targeted CAUTI rate of 4 or less hospital-wide events per year. So then we move into AIM-2, and the analysis for AIM-2 actually produced some really surprising results. Initially, this was kind of a big disappointment for us when we were doing the final kind of data analysis. As you can see here, the improvement initiative did not result in a decrease in total urinary catheter days. And you can kind of see here that we have in the figure, you have the blue ones are the 16 weeks before implementation, and the red bars are the 16 weeks during implementation. And you can kind of see there that our urinary catheter days were consistently running higher throughout the entire implementation period. And, that was concerning considering one of our goals were to decrease total catheter days. Obviously, with these urinary catheters, as I'm sure a lot of you are familiar, one of the biggest goals, not only to decrease infection, is also to increase the amount of time that these catheters are in there. First off, we don't want them in there. Second off, the longer that they're in there, the higher chance you have for infection. So it really was a goal to get those down. The final analysis actually revealed a 10.5% increase in total catheter days during the innovation. But it's also important to note that this was not statistically significant. The p-value was only 0.121. These findings also really didn't line up with the similar studies or bundled intervention approaches that we had looked at in some of the other research that was done, where they were found to reduce total catheter days by as much as 27.5 to 35%. So if you look at this chart here, basically we just kind of broke down like the mean and the median of each of the periods, and you can kind of see that during each time period, if you look at the pre-innovation period, the mean was only 93.75. And during the innovation period, when we were supposed to hopefully be going down with those catheter days, the mean was actually 103.56. That's a pretty significant jump. I mean, looking at this, it was multifactorial, and we're about to get into kind of what we thought may have caused this and the additional evaluations that we did to kind of look at the reasons why this number actually went up. So these unexpected results really did prompt us to go into a further review. So we ended up pulling retrospective data for the number of ICU patient admissions. We also looked at total patient days, and we looked at the reason for use for these, and we analyzed them for each time period. So the admission data for that period actually revealed that the ICU admissions were 3.68% higher during the intervention period. And based on this finding, we also decided to take it a little bit farther to account for those kind of fluctuations in census, and we ended up calculating the device utilization ratio for those time periods. So what the device utilization ratio does is it allows us to look at the number of catheter days divided by the number of patient days. And this really allowed us to track the urinary catheter use over time while accounting for those fluctuations in census. So we really could get a more true number of what those differences were. The device utilization ratio was also higher during the intervention period at 0.63. compared to 0.57 in the pre-intervention phase. So with this calculation, it really did make it so that we could truly say there was a higher overall urinary catheter usage throughout that intervention phase. So based on that and the higher use, we really wanted to look at why they were being used more. Was the use appropriate? Were they in for the proper reasons, or were they being left in longer than they should have been? So we also pulled and compared the reason for use data between both of those time periods. Post-intervention analysis revealed a larger percentage of patients requiring ongoing urinary catheter use related to certain things like intravenous sedation, things like mechanical ventilation, and use of intravenous inotropic agents compared to the pre-intervention period. So obviously with these like higher acuity critical care patients, prompt removal of urinary catheters is, a lot more challenging. If the patient's obviously on something like ECMO and they're on 8 different drips and they're on a ventilator, these patients obviously need their catheter. And if you're in a month where you have a higher amount of patients like that, then sometimes that can, that can increase your urinary catheter days, and there's only so much that you can really do to drive those down. So we kind of looked at this and we kind of, we spun it around a little bit. Despite the initial disappointment we had from not meeting that second aim, we actually were able to pull away some positives from all this. Despite there being a much greater chance for an opportunity for infection with those catheter days going up so much, we actually were happy that our CAUTI rate still went down. So we really thought this helped support the efficacy of our other interventions that we were using. And then we get into aim 3, where we also got some very promising results. The post-intervention results exceeded our initial aim of 75% overall documentation compliance. There was also a significant 33.3% improvement during the intervention phase. A separate review of the individual elements also have found that our nurses actually increased their compliance with documenting catheter-related patient education and also documenting in catheter use. We were still struggling in both time periods to find the documentation on catheter care, and probably that was the area where we could still stand to have the most improvements. And we found that presence of an order, which sometimes we thought maybe was a problem, we have found that that really was not a big issue. We actually had 100% compliance with being able to locate that indwelling urinary catheter order in both periods. So that was not an issue at all. And this kind of goes through that same thing again here. We can just kind of see that documenting catheter care was an area that we needed to continue to improve on, but otherwise the documentation had improved very significantly with the study. So I kind of wanted to take a minute to really talk about the biggest strengths of this project, and it was kind of like something that I don't think that we were necessarily expecting, even when we were kind of reviewing this at the end. The best aspect of this improvement project in the end was ultimately the overall simplicity. If you think about it, the interventions that we used were very direct, they were efficient, they didn't involve a lot of work for the nurses. So they really increased the compliance and, made people, more willing to accept the change with that. I think the other benefit was there are really few direct costs or necessary equipment associated with this. You think about back to those other studies where they tried to get those antimicrobial drainage bags and things like that. Those are all things that essentially drive up the cost for your facility. And with something like this, you're really focusing just on education and adding a couple of extra clinical tools through the removal list or the removal protocol and the checklist. And those are things that you could really implement with relatively low cost. The other benefit is because this was, so efficient and really kind of easy, it's something that you could easily adapt for hospital-wide use. And that's actually kind of how this went. When the project was over, it was so successful. And so they were easily able to start kind of converting this into, a similar program that could be used for the nurses and the other med-surg floors and everything that we could use hospital-wide to work on driving down those CAUTIs for the entire institution. And the same bundled approach, because it is, so easy and you kind of have those very direct, like you focus on education or you focus on practice, this can simply be adapted into other areas as well, including things like other healthcare-associated infections. And we'll touch base on this a little bit more in a later slide. So with this project, I would say that our biggest unexpected success of the initiative was really how crucial the educational component ended up being for this project. It's really easy to underestimate the importance of continued education and those refreshers on basic skills. They're often things that we can easily take for granted. However, when we got the post-intervention feedback from the staff and from management, we also found that these educational elements were extremely helpful to them. I even know when I first started it, this was not the finding that I expected. I thought, if anything, the removal protocol and the checklist would be our, our biggest areas that were most successful, but we actually ended up finding one of the, this was opposite of what we had expected. And I think partly what ended up making this project so interesting. I think it's important to remember that while intensive care unit nurses have been equipped to care for incredibly complex patients, the basic aspects of patient care still remain very, very essential. The results in this feedback really closely mirrored results of another quasi-experimental study that I had reviewed, in which biannual training sessions were also highly effective in their CAUTI reduction. So I think it's important to remember that most UTIs are avoidable events. These don't have to happen. A lot of times there's simple changes that we can make to prevent them entirely. And sometimes just implementing some of these nurse-driven interventions can really play a major role in reducing these events. There's things like the important foundational skills, like when we go back to like the education that we talked about, like daily care and aseptic technique and things like that. Important foundational tasks like strict aseptic technique during insertion and maintaining closed systems can do things like limit biofilm formation in the closed tract, and performing proper perineal care in patients with indwelling catheters can also limit migration of GI microorganisms into the urinary tract. So in vulnerable critical care populations, each of these skills are really important to help reduce CAUTI rates, and ultimately by doing that, you can improve patient outcomes and you can improve healthcare costs. I think as well, nursing leaders can also help promote continued education through things like annual skills fairs. These can focus on current and emerging evidence-based nursing practices, and they can also allow for continued improvement in patient care and patient outcomes. So when we look at the conclusion, the future implementations here, we'll kind of wrap everything up by talking about these a little bit more. I hope you have noticed through this presentation and talking about the interventions that we implemented, ultimately how this improvement initiative proved to be quite successful. We really had a significant reduction in CAUTIs in the ICU and throughout the hospital ultimately, and found that using this bundled approach, such as this one, can be very effective for quality improvement in the intensive care settings. But this can also be easily adapted for hospital-wide use. The multifaceted approach uses both education and practice-based interventions, and as we discussed prior, this can easily be adapted and used to implement improvement initiatives for other CMS-targeted healthcare-associated infections. You can use a very similar model for other things like catheter, central line-associated bloodstream infections, things like ventilator-associated pneumonia, surgical site infections, and even hospital-acquired C. diff. If you look at those, you can kind of set up improvement projects where you kind of have the education for your nurses or your annual skills fairs or biannual skills fairs. On that, you can talk about specific things. You can talk about things like ventilator care, what's the appropriate way to, to maintain the vent and the tubing. But then also you can do some other education for that as well and implement checklists or clinical support tools within your EHR that can be beneficial as well. And ultimately with that, you can really help drive down these infection rates. So if you think about this on a large scale practice improvement, these problem areas could result, using methods like this could result in significant improvement in patient outcomes, also decrease hospital stays, and ultimately reduce the overall healthcare costs as well. And if anybody wants to look up any more of these, you can see a lot of the references that were used for this. Feel free to open any of those up and kind of look into some of the other studies more that dive deeper into some of the other interventions that were used and some of these other bundle-based approaches, and you can see the results that they got from those. I find some of these to be very helpful, and some of them may be helpful in your practices as well. And that actually concludes the presentation here. Christine, I'll now turn the program back over to you.
That concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. So Holly, as we wait for questions to come in, what was the most surprising or unexpected outcome of this initiative?
Thanks, Christine. Yeah, we touched on this in the presentation somewhat, but I'm glad that you brought this back up because ultimately, for me, when I came in to do this project, I have to admit, at first, I wasn't even that excited about it. You're thinking, well, urinary tract infections and catheter care, like, I mean, it doesn't seem like it's something that's that difficult. And I was really surprised, and I actually know the other people that I worked with were really surprised as well at the end on how important the education ended up being. And I think we had talked about this a little bit earlier, Christine. A lot of times, it's some of those basic daily things that nurses do that sometimes kind of fall by the wayside. I know we've kind of all done it. It's things like daily catheter care that you kind of forget. You forget like the right way to do it, or sometimes things have been done differently for so long that you don't necessarily realize the rationale behind what we were doing, and things can start to change. And then, it's also other things like appropriate positioning and when to correct appropriate samples. All of these things, as minor as they seem, all can kind of, culminate into this bigger issue, which ultimately results in driving up these infections. So really the biggest surprise to me in the end was truly how crucial the educational component was. I had some nurses that I had known for years that had been ICU nurses, and they're like, I couldn't tell you the last time that I put in a catheter. They usually come up with them from the ER. I'm glad we did that because I didn't really remember how to do it the appropriate way. Or even some new nurses that said, hey, we actually never really practiced this a lot. Or some people that really just forgot the appropriate sterile way to insert a catheter. All those little things, the more you start to hear them, the more you realize, like, wow, this really was a beneficial project that we obviously needed. And it kind of reinforced how we may need to do something similar for other things as well to kind of keep those things kind of in the forefront when we're doing our daily practice.
Holly, what was the most challenging aspect of the initiative?
So I think the most challenging thing for this, and fortunately I think this has kind of been fixed at this point, is as I mentioned in the middle of the presentation, during this period we were actually at this kind of transition. We were still using our old EHR system, which for us was actually very antiquated. It had been for years. It was very difficult to use. It was very difficult for, I think, like IT and like the informaticists to kind of write things into that program. And so for us, the daily checklist, that was definitely difficult. We really had to work with that. It took a lot of work to get it up and running and working efficiently. So that was a challenge. And then the other part of it was with the removal protocol. Kind of hindsight, that's the one thing that I'm kind of most disappointed about, is that because the removal protocol for us wasn't able to be built into the EHR, it also made it really difficult to track. So the nurses were trying to use it, but it wasn't really easy at the end to look at the data to really see how effective that element of the improvement project was. So that really was a challenge. Fortunately, with most of the new EHRs and with the one that we're using now, they can build a daily checklist and that removal protocol right into the orders. Like a single pop-up, it'll ask the provider, like, are you okay if we use the removal protocol? They say yes, and then it automatically flows through to the nurse's orders. So it definitely makes it easier to use.
Holly, a question has come in from Katie. She's asking, can you comment on sustainability of the project and success?
Yeah, so I actually reached out to the director of our infection control a couple of months ago just to kind of see where things were. Because obviously when I went from being in like the neurosurgery field over to dermatology, I wasn't kind of in that setting on a day-to-day basis. And so I was just kind of curious to see how they did. And fortunately, they actually have set up the training programs like we talked about hospital-wide, and we do have the checklist and the removal protocol now built into the EHR. So they really are using something very similar to this on a hospital-wide scale. But with COVID and with the increased admissions that we've had and everything recently over the last year and a half, obviously, as I'm sure a lot of other institutions are dealing with as well, just census has been high. Some things have fallen by the wayside. But even with all of that, while the numbers are not as good as they were at the end of this intervention period, they actually are still significantly better than they were back in 2018 when we initially realized, hey, we have a really big problem here. So that's really been helpful too. And the other thing with that is I think that with sustainability and everything, it has been fairly easy to sustain. We have a CAUTI reduction task force. They're able to kind of review the stuff on a regular basis, and we can easily make the changes that we need to make as well. But yeah, it's proved to be very effective, and they're still, doing well despite some of the complications that all healthcare has had in the last year and a half.
Holly, how can this concept be applied to the prevention of other healthcare-associated infections? I know you touched on this briefly, but could you just elaborate a little bit more?
Yeah, so if you kind of look at things like you have like the central line bloodstream associated infections, or you have like VAPS, ventilator associated pneumonia, if you kind of think about that, like the concept for all of them is still relatively the same. Like you have your nursing staff, you have your equipment, your ventilator, your tubing, things like that. So what you could easily do is you obviously would want to look at studies to see what interventions were appropriate for those specific things. Let's say ventilator-associated pneumonia. You could easily look up a couple of interventions and studies where they were found to be very effective, whether it be like, with closed systems, certain like tools or, methods that they use, and look at that, use some sort of like checklist to make sure that, the ventilator care is being done appropriately every day, something similar to what we did with the urinary catheter checklist, and also to look at reasons to make sure the appropriate use and all that is in line. But then you also could implement an education for that as well to remind staff of appropriate like trach care or, ET tube care and, ventilator suctioning and the appropriate ways to maintain closed lines. All of those things, if you look at implementing the educational component combined with the intervention component and combine those into one of these bundled approaches, I feel like this could easily be adapted for all of those hospital-acquired infections, and we really could see significant improvement using that approach.
Thank you, Holly. How receptive to this intervention were the frontline nurses? This is a question from the audience.
Yeah, so they were actually very receptive. So remember too, I functioned as an ICU nurse for a lot of my career, and I know even from that, like that's part of why I wanted something that was simple, that it was easy for them to do, because I know we all have stuff we have to do. There's always required education. There's always things that we have to go to. There's annual learning. You have to take care of your patients. There's all these things that you have to do on a regular basis. And I firmly believe from my experience and from what I have seen that when these things get too complicated, that you're kind of dead in the water from the very beginning. So with this, because it was super easy, we kind of had these, I had this education module that got sent out. It was something that, they could kind of watch it kind of here and there and finish it up, take their quiz, be done with that during their shift. And then at some point while they were working, they could have somebody watch their patients for a little bit. They could go do the skill sign-off. It was really easy for them. They didn't have to take it, time out of their day, time away from their family. They could easily do it while they were there. And then the same thing with the checklist. The checklist was also something that was super simple. There wasn't a lot involved with it. You didn't have to worry about having to go find the paper, fill out a paper, give the paper to the supervisor. It really was, you just clicked on the link, and I actually had set it up that it was drop down, so like you didn't have to free type anything, which also limited room for error. They simply would just have to drop down and click each of the appropriate options for the things within the checklist, and that was it. So it was something that they could do very simple. And the nurses actually, I think partly because I work with them so closely as well, but I mean, they were all kind of excited for it. And I think as they kind of saw the improvements, they kind of were taking pride in what they were seeing, and it really went well with them, I think.
We have a question from Gretchen. She would like to know what cleanser was used for maintenance and bathing. How often were the catheters cleansed, and by policy?
I actually don't have it in front of me now, but I think that true catheter care had to be done. I think it was once a shift, and then more if needed for like soiling, like obviously if a patient was incontinent or something like that. But our standard practice actually is to just use soap and water and a clean washcloth. And like, for example, we were actually just talking about this, Christine and I, before this got started. Things like that are really important. You don't want to be using a washcloth like, somewhere else on a dirty wound or your face or whatever, and then be using that one to clean the catheter, because obviously then you're going to introduce bacteria into that urethra and ultimately, cause that tract up into for infection. So you have to be really careful with stuff like that. But also the other thing with the perineal spray is that it was like a lotion-based moisturizing perineal spray. It was something that was kind of just like specific to our institution that we got through like a company. I'm not exactly sure what the brand was, but it was specifically advised to not use it for catheter care because of what was in it, because it was actually found that it would actually inhibit bacterial growth and it could actually increase your chances of urinary tract infections. So technically, it was never supposed to be used for catheter care, and some people were aware of that, but I would say by vast majority, a lot of the nurses had no idea. They had this perineal spray, it said perineal cleanser spray, they would use it to do their catheter care. They would just squirt it on and use one of like the throwawayable wipes and do it, and off they go. And in the meantime, they didn't realize that they were potentially increasing the actual rate of CAUTIs with that care.
Another question for you, Holly. What impact can COVID-19 have on healthcare-associated infections and the interventions utilized in this initiative?
So I think that this is a really important question. You know, obviously, we wouldn't have had to even think about something like this a year and a half ago, but we have all been in very different situations because of COVID for the last year and a half. I think some of the people that have been affected by this the most are our frontline healthcare workers, specifically our new graduates in nursing. They really, a lot of these girls that have, or a lot of, I didn't mean to say, a lot of these students that have come out of school and are starting as like new graduate nurses have not had a lot of clinical time. I mean, a lot of us put hours and hours into clinical time, and unfortunately for them, they have not had those opportunities. And so something like inserting a catheter into a mannequin is certainly a lot different than inserting a catheter into a, into a real person. And also just doing those daily things for care that are so important. Those are things that those nurses just have not been as exposed to. So it's certainly more difficult for them. I know partly because of this, they had seen this a lot at my local hospital. And so they actually have been doing more kind of annual or more training sessions for these nurses. They're bringing them in, they're having training sessions in the beginning, and then they're repeating them again in a few months. And then ultimately it goes to them yearly after that, but they've really been trying to do that to support them just because they haven't had that experience in that clinical time. The other thing too is that, and this is kind of part of the reason I think that the infections kind of went up a little bit during this recent time period, is that our admissions and our census and everything have went up considerably. You know, obviously everybody's dealing with it at their hospitals as well, but like staff shortages and things like that have all made it challenging. And so sometimes I think that some of those care aspects can easily kind of get lost or missed in all this. And even with all of those complications, you know, we've still been able to maintain numbers that are pretty good for our facility.
I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation or certificate of continuing education, please feel free to direct any inquiries to Shelley Mixel at shmixell@pa.gov. This concludes our webinar.